Good evening to all of you. First of all, let me thank the organizers, STIC, especially Edlin sir, who was a teacher of mine during my MD days, and my very close friend Damodaran for the opportunity given. This is how a laser console would look like. It's a very heavy console, more than 200 kgs, and however, the laser catheter is a very user-friendly device. It's a very user-friendly catheter. It goes through a 6-friend system, and then it's a monorail system. We have two modalities. You can manipulate two basic things. That is, you can adjust the frequency, you can adjust the energy that's being delivered at the lesion site. So once you increase the energy, then you have a bigger cavitation bubble, which means that you have a better lesion preparation. So at higher energy, a better lesion preparation, but then one should keep in mind that the chance of complications are likely to be more. Well, this is how you would do a lacing with a saline. Let's say when you do the lacing inside the coronary, you continuously flush saline. So then this is how it would look like. However, in the second image, you could see that that's lacing with the contrast agent. That is, when you do the lacing inside the coronary, if you inject contrast, that is 50-50 or 25-75 contrast, then you tend to have bigger cavitation bubbles, which again means that you have much more energy delivered there, much more better lesion preparation, but again at the expense of complications. Well, how does laser help us in calcified lesions? Well, first of all, I start with the laser in ISR. This is a post-ABG patient, undergone stenting almost 7 years ago, now present with effort angina. This is a vein graft to the D1. He also had a vein graft to the right coronary artery, which also had an instant restenosis. Here you could see that in the proximal portion, there is a tight instant restenosis. Almost 7 years ago, this stent was implanted. Again, in the lower frame, you could see that in the stent boost image, you could see that the stent is not well properly expanded also. So because the stent was not properly expanded, we thought that we go ahead with lacing. We started with 0.9 millimeter laser catheter. We did saline lacing. We did contrast lacing. Again, this was helped with the help of a guide extension catheter. Then we went ahead with balloon dilatation. That was an angiosculpt. It easily opened up. Then we finished the procedure with a drug-eluting balloon, and we could achieve good flow in that particular vessel. Well, again, similar to that, he also had a very critical stenosis of the stent in the graft to the right coronary artery. It was a calcified stenosis, which is proven with IVUS imaging. And then again, we went ahead with lacing, primarily because it was a calcified restenosis. Again, it was extremely difficult for us to get across that particular lesion. We used a guide extension catheter. You could see that the guide extension catheter is very close to the lesion. Despite that, with saline lacing, we were not able to cross the lesion. In the second image, you could see that we were injecting contrast into that while lacing, which means that we have better bubbles, better energy being delivered there. So then you could see that the laser catheter went across. And again, for better further tissue extrusion, we further did contrast lacing. Now you could see, if you carefully watch in this particular image, you could see that there are small air bubbles going down the vessel. That's primarily because of the lacing at high contrast medium. These bubbles are not really dangerous. This doesn't go down and occlude the microvasculature, because it just expands and collapses. So then you wouldn't have a slow flow inside the vessel. And again, IVUS revealed that there was significant amount of calcification over there. And following that, you could see the image taken. You could see that there is absolutely no slow flow. So these bubbles that's produced with contrast lacing, it's usually not dangerous. Then finally, we went ahead with balloon expansion. That is this is an angiosculpt followed by a non-compliant balloon, and finally we settled down with a drug-eluting balloon. And that was the final result that we could achieve in these two situations. That is one ISR to the stent to the diagonal branch, and then to the right coronary artery. Well, it's excimer laser is also useful in calcified uncrossable lesions. This is an example for that. This is a patient who presents with effort angina. You could see that there is a very critical stenosis in the right coronary artery, which is heavily calcified. If you look at the lower frame, you could see that it's an ugly calcification. It was extremely difficult for us to wire this particular lesion. We couldn't wire with a run-through wire, which is a workhorse wire. We had to wire with a Fielder XT wire. Again, with great difficulty, we were able to wire it. The plan was to do rota. We were not able to get the caravel catheter, the microcatheter, across the lesion. At that point of time, we decided that we consider this an uncrossable lesion. Go with a lacing. That's the initial image, 0.9 catheter with saline contrast. The second one with the saline lacing. The second one with contrast lacing, and the third one with the help of guide extension catheter. We tried to get it across. Finally, we were able to get the laser catheter across the lesion. Once the laser catheter is across the lesion, we were easily able to get the guide extension. We were easily able to get the microcatheter across. Then had a rotafloppy there. Then started burring with around 0.25 bar followed by 1.5 millimeter bar, and finally the third image shows that 1.75 millimeter bar, primarily because it was a nodular calcium over there. So all rotablation was done at 180 as well as 200,000 rpm. Finally we were able to dilate with angiosculpt, and then the stent was tracked with again a guide extension catheter, and finally we were able to deploy the stent. We were able to achieve good result in that particular patient. Well, this is another 70-year-old doctor who had undergone CABG 20 years ago, recurrent rest angina, presented to a nearby hospital. They wanted to have a rotablation done. However, the microcatheter could not cross the distal lesion, so he was referred to us for a possible lacing. So here you could see that there is significant amount of calcification in the distal right coronary artery, and then we started off with lacing. We wired with a regular run-through wire, tried lacing with a 0.9 catheter. It was not going through. Tried contrast lacing. It was not going through. Then again we, with the help of a guide extension catheter, we again tried to get the laser catheter across. It wouldn't go through. It wouldn't go through. But then the next thing that happened was we were able to get the fine cross catheter across, probably because the laser catheter made the lesion much more supple and much more flexible, so that we were able to get the microcatheter across, exchange with the rotafloppy 1.25 bar followed by 1.5 millimeter bar at 200,000 rpm, and finally again we had to do a lot of lesion modification with IVL there, and finally a couple of stents were deployed there. These were the two stents that was deployed, and finally we were able to achieve good results. Despite doing laser, we had to use non-compliant balloons, OPN balloons, we had to use IVL, and that is how we were able to achieve this sort of good results. So primarily laser, it acts as a complementary tool in managing these sort of extremely calcified lesions. Well, regarding undilatable lesions, this particular patient had undergone 2 stents to the right coronary artery. He had undergone 2 procedures, which means that he had overlapping stents in the right coronary artery. So 2 layers of metal. Again, you could see that patient has come back with restenosis. There is a very critical stenosis in the mid-right coronary artery, present with an acute coronary syndrome. If you concentrate at the first image, you could see that both the stents are under-expanded. So primarily, we wouldn't want to deploy another third stent over there. We somehow wanted to get away with a drug-eluting balloon over there because it was an under-expanded stent. So our plan was to open up that under-expanded stent. We went ahead with lacing. Again, it was again saline lacing followed by contrast lacing, and once we did the lacing, we were able to get across with the OCT catheter. You could see in the first 2 images calcium inside the stent, calcium outside the stent. There was significant amount of calcification over there, which was managed with laser, and finally we were able to open up the lesion with a non-compliant balloon at 35 atmospheres. That was OPN balloon, and those are the pre and post procedure images. We could achieve a decent result with a drug-eluting balloon over there, and these are the pre and post images of the under-expanded stent. You could see that the first image, the under-expanded stent, 2 layers of stent, it is opened up with lacing as well as OPN balloons, and we were able to achieve a minimal luminal area of more than 5 millimeters square and settle down with a drug-eluting balloon. This is another patient who had an anti-wall myocardial infarction, 83-year-old man. He underwent stenting to LAD. We saw that there was a lesion in the right. We thought that we'll manage that non-culprit lesion also at that point of time. So we tried to manage that. We went ahead with a guide extension catheter, dilated it, and then stented it. That's the stenting being done. Balloon dilatation was done with a 2.5 millimeter balloon. The stent was deployed there. Once the stent was deployed there, we found out that it was under-expanded. You could see that the stent is under-expanded in the mid portion. The next thing was we wanted to get a non-compliant balloon across there and dilate it. None of the non-compliant balloons would cross that particular area, probably because there was a ridge over there. None of the balloons would go across that particular area. Despite having a push with the guide plus catheters, it wouldn't go through. So we decided for lacing. So that was again the lacing being done. Once the lacing was done, we were able to get across with the non-compliant balloon, dilate it, and then we were able to achieve good results in that. So that was an expanded stent which was managed with lacing followed by non-compliant balloon. Well, this is another patient who had an stenting to the LAD long ago. He presented with effort angina. You could see that there is tight stenosis in the proximal left anterior descending artery, and it was managed at a nearby center. They were not able to dilate the lesion, so he was referred to us. And once he was in our center, we did lacing. We did lacing. We started off with laser. The options were rotational atherectomy versus lacing. Because it was a discrete lesion, we thought that he also already had a 6 French sheath in the radial artery. We thought that we'll try with lacing. If it doesn't work, then probably we'll go with rotablator. So these are the pre and post lacing images. You could see that there is a significant plaque modification. These are the pre and post post-procedure, post-lacing images. You could see in the cranial view also, there is a significant plaque modification. We did an OCT after that. You could see that the luminal gain was quite good. It was 3.28 millimeters square. And then we saw that there was significant amount of calcified nodules there on OCT. So went ahead with IVL. Those are the IVL images. Following that, you could see that there are significant amount of fractures there, and that was the final result following the stent implantation over there. So this was just to highlight the fact that this particular patient could have been managed with the help of rotablation also, but then because we were working with a 6 French guide catheter, we thought that probably we'll go ahead with that particular catheter and settle with that. A patient with acute myocardial infarction which was managed in a nearby hospital, they were not able to get across the lesion. This was the right coronary artery which was totally occluded. They could not get across the lesion which was a calcified lesion and was referred to us. You could see that it's a calcified right coronary artery. We were working with a 7 French guide catheter, and we initially thought that because it was an uncrossable, we thought that we'll straight away try lacing, because rotablation in a setting of acute MI may not be all that great because you might end up having a slow flow. So we decided that we'll do a lacing with a 0.9 millimeter catheter. So that's the lacing being done. Following lacing, we were able to get across with an OCT catheter. You could see that the flow is restored well. Following lacing, we did an OCT. We made out that there was significant amount of calcification there, nodular calcification as well as concentric calcification. After lacing also, we were not able to dilate it with a balloon, so we decided that we'll go ahead with a rotablation. So that was a rotablation with a 1.75 millimeter bar, and subsequently we were able to dilate it properly and then stent it and finish the procedure. So dear friends, in a calcified lesion, we do have many options to manage these particular patients. We have the ablation therapies like rotablation as well as orbital atherectomy. We have the balloon-based technology. So in a heavily calcified lesion, many times you would need two strategies. That is, you would need an ablation strategy. You would also need a balloon-based strategy in a heavily calcified lesion. But there are certain niche indications wherein you would prefer using a laser technology. That is, when you have a heavily calcified lesion, you decide on a rotablation or orbital atherectomy, you're not able to get across the lesion with a balloon or a microcatheter, then that becomes an uncrossable lesion. When you have an uncrossable lesion, try to wire with a rotafloppy or a wiper wire. If this doesn't happen, if it's difficult to wire with the rotafloppy, then at that point of time, probably laser would be the only option to get across the lesion. Convert the uncrossable lesion into a crossable lesion, then go ahead with a microcatheter, cross the lesion, exchange it for a rotafloppy, and then go ahead with the procedure. Thank you once again for the patient hearing.